Today, we're going to talk about a couple things. We're going to talk about QTC interval and calculation of QTC interval, and we're going to talk about, somebody asked about CA 125 for congestive heart failure. So to start about a QTC interval, remember a few things. Number one, if your EKG machine based on the AI is reading QTC interval, you can go with that number. You don't really need to calculate yourself. But if your machine doesn't really calculate the QTC interval, what you can do, you can divide the RR interval by the square root of, you can divide the QT, the measured QT, by the square root of the RR interval. If your heart rate less than 100, and then if your heart rate above 100, what you need to do is the third of the square root. You can divide the QT interval on that, and you can get the QTC interval. Remember, when you get the QTC interval, you have to take into consideration the QRS. So if you have paced rhythm, or you have bundle branch block, you really need to take about between 80 to 100 milliseconds of the QTC interval. Because when you measure QT interval, you're including the QRS, and the QRS prolongation has nothing to do with the repolarization of the heart. Actually, it has something to do with depolarization of the heart, and should not be part of the QTC interval. So let's say if we say that we start patient on medications such as sotalol or dofetilide, and we want to calculate the QTC interval, and they calculated the QTC interval 560, and patient has a paced rhythm or left bundle branch block, take about 80 or 100 milliseconds of that, you're going to have 480, which is going to be acceptable. So always remember that. Also, there's another thing when it comes to starting medications which can prolong QTC interval. You don't really need to worry about anything if your QTC interval less than 500 milliseconds. And there's a lot of fear of the prolongation of the QTC interval and the torsades, but it's extremely rare that you're going to have torsades if QTC interval less than 550. So just keep that in your mind. If your QTC interval below 500, you should not really worry about it. If QTC interval start climbing, be above 520, something like that, then you have to be worried about medication interference, electrolyte abnormalities, and so forth. And always remember that the QTC interval calculated by the machine, EKG machine, is pretty damn accurate. Actually, there are some data about EKG AI or EKG machine reading EKGs, and the accuracy of the EKG machine is about 91, 92%. Electrophysiologists get it right in about 65%, and cardiologists about 34%. Okay, keep that in your mind. So AI is probably better than us when it comes to EKG readings, but still, sometimes the EKG reading machine is not that accurate, and sometimes you have to keep an eye on that and check it out. But for measurements, most of the time they are accurate. Anything about the QTC interval? So don't get scared of the QTC interval. Don't get scared of QT prolongation. It's not extremely is not like every QTC interval above 480 or 500, you're going to end up having torsades. It really doesn't work this way. Otherwise, 20% of the population will end up having torsades.
If we have any patients that are on sotalol, how often do you, like long-term patients, would you recommend getting an EKG and monitoring the QTC?
3 to 6 months.
Okay.
Yep, and document that in your note.
Got
Whoever
it.
works with me in the clinic, they know that if you have patient like that, they have to document the QTC interval in the note. And remember that this medication cleared by the kidneys, and patient population that we work with, elderly patient population on diuresis and so forth, they may have changes in their GFR. and the changes in GFR is going to change the clearance of the medication. So you really need to be very careful. Also, they have electrolyte abnormalities, low magnesium, low potassium. Both of those can cause QT prolongation. So you really need to be careful about that. 3 to 6 months is reasonable. And always remember that weight can change in these patients and kidney function can change. So if you inherited some patient with a total of 120 or 160 and they are 100 pounds and GFR is, let's say, 42, you need to be careful about adjusting medications. Don't take anything for granted. So always remember these kind of medications, they really need to adjust them. And always remember polypharmacy issue with these patients. You're adding medications. Excuse me, you're adding medications, and the primary care provider and the hospital is adding medications. They're going to the GI physician, adding medications, and it just becomes polypharmacy. So the less medication you use, the better you're gonna be, and always use some PRN stuff or stuff that for short term. They add omeprazole for little GERD, and all of a sudden this omeprazole becomes part of their medications for the rest of their lives, and that's not really healthy. You're adding Lasix also. I mean, just do it every other day for a couple of weeks and then reevaluate and then do some more visits to these patients, get some blood work, and then sometimes they may need to live with some lower extremity edema. There's nothing wrong with that, right? But you don't want to kill the kidneys. And sometimes actually they may need to live with creatinine 1.7. Nothing wrong with that either. That's their dry weight creatinine, and that's acceptable. Some physicians, some nephrologists, they like creatinine to be as low as possible. But guess what? You're going to end up having hypervolemia in these patients, and that's CHF exacerbation. So that's not healthy either. So look at the patient, don't look at the numbers. Treat patients, don't treat numbers. And if patient is doing fine with lower extremity edema a little bit, no big deal. Any questions? All right. Somebody asked, I think Whitney, you asked about CA 125 for congestive heart failure. Actually, there have been some literature I've been seeing for the last couple of years talking about CA, which is carcinoma antigen 125. Usually, we use that for ovarian cancer. But they found there are some case reports and some studies identifying actually elevation in CA 125 in the hundreds in patients with congestive heart failure, especially right-sided heart failure. I would not really rely on that, and I would not really try to be dependent on this CA 125. I think we should go by BNP and pro-BNP. In cases where 125 CA 125 is elevated, there's a possibility that's not related to ovarian cancer, or it might be related to congestive heart failure. Just keep that in your mind as in your differential diagnosis. But I would not really use this as a marker for diagnosis or treating congestive heart failure yet.
Got it. Thank you. I had just read an article about it also, and I was just curious on how often it was actually being used, and
We don't use it.
if that was something.
No, we don't use it. We don't.
Okay.
I don't encourage to you, and it's going to be very confusing. Like
That's kind of how I felt, but I just didn't know if it was.
No, somebody said,
something.
you're going to act smarter than others, and something this burns. With
Yeah.
the hell is he giving
Exactly.
calcium? Is the patient having ovarian cancer or something? So any other questions, guys? I think we're good. Anything you want to discuss in 5 minutes? All right. Any topic you want to discuss next time? Okay. I want to mention a couple of things. Newly, we're having a lot of studies recently talking about single antiplatelet agent in the setting after MI and after stenting. What I recommend for all of you, start using dual antiplatelet agents for 1 month only, and then after that, use aspirin or Brilinta or Efient. Remember, there's a black box warning if you have Efient in patients with history of ischemic stroke. Remember that. Efient, ischemic stroke, contraindication, don't use it. And be less aggressive with thrombotic agents. And the reason we are less aggressive because the stents we're using right now, they have very good scaffold and they have less profile compared to other stenting, and they don't have that much, they don't need that much antiplatelet agents. And always remember, down the road, if you have patients with atrial fibrillation and they are on anticoagulation, you may get away with anticoagulation, no need for antiplatelet agents, even if they have CAD disease. And remember the patient that your patient population, they are not healthy 50-year-old bodybuilder. No, they have multiple comorbidities and they have underlying anemia almost all the time. Just keep that in your mind. So antiplatelet agents will becoming less and less needing a need of antithrombotic agents, antiplatelet or anticoagulation, or antiplatelet in the case of CAD disease and peripheral vascular disease. So less is more in this patient population. So just remember that. Recently, the SGLT2 inhibitors, there's a huge emphasis on these patients in cardiac in heart population, and we need to be liberal in using those medications if you want to be in adherence with the guideline-directed medical therapy in heart failure or CAD or peripheral vascular disease patients. So just always remember that. And remember to use intermittent diuresis. And if you're going to use diuresis at times for congestive heart failure patients, just remember to check electrolytes. Your patient population, they have a lot of electrolyte issues, hypokalemia, hyperkalemia, and so forth. So you have to be careful about that.